Now, what are the goals of therapy? Our goals of therapy are no seizures, no side effects. That's the mantra from the Epilepsy Foundation of America. That's the mantra from the European, the Asian foundations, the Australian, everyone else. And that's what we want. In reality, some people have a little bit in the way of side effects. If it's minimal and not interfering with life and they don't view it as bothersome, they may be willing to tolerate it. Perhaps then we should be willing to tolerate it. If they're having seizures, that's a problem. I think we absolutely do not want tonic-clonic seizures. Those are associated with SUDEP, sudden unexpected death in epilepsy. So there's an increased risk of dying. There's an increased risk of injury. Those we absolutely want to do everything we can to stop. Nobody dies from absence attacks. They're very unlikely to cause injury, but they still can be limiting. You can't drive if you have abscesses. They may interfere with learning for a student in school. And for that reason, we would like to try to stop them as well. But again, one might choose not to be quite as aggressive depending upon social circumstances and what the patient's needs are. And balancing side effects and control then factor in. Another question that could be posed is, do the newer drugs have advantage over the older drugs? And I guess the answer to that question is yes and no. I don't like the notion of newer and older drugs. There are drugs with different mechanisms, drugs with different side effects. Just because something happened to have been developed in the 1970s and another one was developed in the 2010s doesn't mean it's newer and better. It could be newer and older or vice versa. We have a number of new drugs that were developed in the 90s and early 2000s that none of us ever prescribed. Tiagabine is one, approved by the FDA. I defy anyone watching this video to find a doctor who's prescribed tiagabine in the last year. It's a newer drug, it's no advantage. Clearly, one of the older drugs, valproate, which was released in the US in 1979, is the most effective drug. It's also got the most side effects too. So you have to balance each, and I wouldn't, again, think about that. Clearly for absence seizures, to break them, to prevent them from happening, it's the T-type calcium channel current. And what are the drugs that impact that? Valproate does, ethosuximide, which is an old drug from the early 60s. That's our best drug for absence, an old drug for that matter. Zonisamide does that as well. These are not necessarily new drugs that can work. And when do we switch from one drug to another? If the old drug isn't working or having undue side effects. Now, another person could say, well, how do I decide what's best? And, to a certain extent, I think you need to use what you're comfortable using and get in the habit. If you exclusively treat epilepsy like I do and see huge numbers of patients, I see so many people, I comfortably use pretty much any of the drugs because I can use them all a lot and still have a lot of experience. If I don't have a huge epilepsy experience, I think it's better to use a smaller number of drugs and get to know them well. And I think the best practice really is to use the drug you know well, believe the peer-reviewed literature, believe placebo-controlled trials, but put it in context too, because trials are conducted on very special populations. You're not allowed in a trial if you have significant psychiatric problems. If you have major medical comorbidities, you're not allowed in a trial. That excludes half of my patients. So we wind up having to do for other things. And then again, you have to use your experience. Always, I think, best practice is start with a lower dose and gradually build up. There's no rush to start somebody on a high dose at once. The average latency from seizure 1 to seizure 2, depending upon what trial you read, ranges anywhere from 6 months to 14 months. You can take a month or two to titrate a dose up. I'm not worried about lamotrigine where I have to do 25 milligrams and then 50 and then to 75, 100 or 25, 50, 100 and titrate up, and it'll take 6 or 8 weeks. I think we generally have time, and there's evidence that even while you're titrating, that you start seeing responses to seizures. And this has been shown in the data from topiramate, for example, where it was looked at. It's been shown in the lamotrigine data. It's not yet published, but the cenobamate data also looks that way, that even at lower doses while you're beginning to titrate, you start to see efficacy. So I think you want to start low and gradually build up. It handles tolerance best. And I think you want to caution people carefully about the serious side effects, let them know what can happen. I always caution about the major side effects. I let people know about particularly cognitive and psychiatric ones. And it's a huge laundry list. You can't mention every one. So you could say you could have a variety of side effects. You can read about it if you want. But if anything is not quite right, anything seems wrong, let me know, and I want to hear from you right away, especially nausea, vomiting, rash, bruising, significant psychiatric or cognitive problems. You want to hear about those right away.